Good afternoon, everyone. I'm Tim Henry from Cincinnati, and my fellow moderator is Rajiv Gulati from Mayo Clinic. And so we have a very interesting group of talks now. We're calling it Going Forward. And we've got some small little changes, and I think we're going to start with Dr. Yader Sandoval, who you've seen like 15 times already. And he's going to talk to us about the future of calcium management, coronary calcium management.
Thank you, Tim. And thank you guys for the opportunity. I think this is a good session just to talk about what's down the pipeline. So I think it's clear to all of us that calcium is the #1 enemy of optimal PCI. I'll talk about a number of things, but for those of you that say, I want to go in depth and understand what's happening in calcium, in the past 2 years, there's just 3 papers that I would invite you to look at it. There's a position statement on management of calcified lesions from the EAPCI group in Europe. Manos and colleagues did a statement on this from Jay Sky and Rob Wrightley that was published a year ago. And Lorenzo and Salini had a beautiful state-of-the-art on stent under expansion, which is, of course, the consequence if you don't deal with calcium. So just to invite you that this is a great resources that are talking what's in the pipeline, what are the trials, what are the criteria, etc. I'll just highlight of all those documents this one. So this is the Sky Expert Consensus Statement that came out last year. And as you can see, it does talk about, of course, the angiographic evidence of severe coronary calcification, and it talks about how to act on all those issues, whether you do atherectomy, IVL, and the stent. So again, very standard criteria that we know of. But I think great efforts with all these guidelines and documents. This field is rapidly evolving. And I fear that Manos and colleagues are going to be writing this document very soon again because there's a lot of things happening. So let me just show you this case if I can get it to play somehow. Can we play this video in the back, please, if you don't mind? So if we can get it to play, this is what we're dealing with in our clinical practice now. This is one of my cases. As you can see from CT, you can identify that there's severe coronary calcification in the LAD diagonal, area of heavy density. I cannot even get an imaging intravascular catheter HDI was across this. So you can see, can you play that again? So you can see how we can talk about these criteria of both angiograms and an IVUS, but there are cases in routine clinical practice that, again, you cannot cross an imaging catheter, that they have severe coronary calcification, and that you have to deal with it. Seems like the video is not playing. Oh, here it is. But these are cases that we use CT. The CT helps us understand that there's a lot of calcium, and therefore you can not be surprised, but you can predict how you're going to respond to this. This is a case that we use an off-label use of the Javelin to get us across. Then we had to use orbital atherectomy to deal with the calcium, and then we still had a horrible calcific nodule and had some area of stent under expansion, and we had to use an OPM balloon. So just to illustrate that this is what many people here, panelists, moderators, and many in the audience, this is what we're dealing with every day, right? And you can see you have to think outside the box, and that there's a number of applications that are not consistent with what's in some of the latest contemporary algorithms. So I want to talk about just 2 things for future directions. One is diagnosis, the other one is treatment. For diagnosis, just briefly, I think all of you by now have heard all these traditional rules. There's rules for IVUS, and arc, and length. There's for OCT, the rule of 5s. One development that I do want to highlight if you're interested is that, to be honest, I really like the rule of 5s because it's easy to remember, but be aware that it was just published by Syed Ali, this revision of OCT criteria. It's the rule of 3s that has 360 of calcium. They changed to a minimum calcium of 0.3 and 3/4 of the vessel circumference more than 3 millimeters. So be aware that there's data out there. But I think we're heading right now, at present, not distant future. The reality is that AI and machine learning is rapidly evolving right now in this field. Many of you, I'm sure, have already this in your practice. So we're shifting away from this traditional logistic regressions, and these are the predictors, and we're going to do this score. We're shifting to where this is practical, right? AI is going to help you, not replace you, but it's going to help you understand this is where the calcium calcium is. You can set it up at whatever threshold it is, and it's going to colorize you where the calcium is. And this is happening with a lot of modalities. So I anticipate that in the very near future, there's just going to be a lot of intravascular approaches that can do this. Now, I was just talking with a number of people here before we started the session. That's what, to be honest, it's really right now, there's just a lot of interest, is that it's already too late if we are in the cath lab and we discover, oh, look, there's very severe calcium. And God forbid, you are at a non-surgical backup lab or the ASC that you don't have the right tools. So there's a lot of interest in saying, can we find the calcium beforehand? And right now, this is a space that there's just a lot of happening. I'm just showing you 2 examples. There's more than this. These are not research. These are clinical tools that you may have in your hospital that are being used, but have been used for prevention and plaque characterization. But for all of us that are interventionalists, you can see we understand there that there's a severe arc of calcium. So understand that from CT, that there's now a number of AI-based modalities that use adaptable use of calcium density and Hounsfield units to understand the morphology of the calcium. And this is something that's rapidly shifting, because if you know it has a lot of calcium, you can allocate to the right hospital, the right operator, and the right time to deal with such cases. So be aware that this is happening. How is this evolving and down the pipeline? It's evolving to 3 concepts that I want to address. One is this issue that now we're moving to 3D modeling of calcium and also calcium distribution. This is what's going right now in the pivotal P4 trial that's looking at CT. And as you can see, it demonstrates this new concept of calcium that we have historically not thought about, which is calcium distribution. We've done this. We've had the privilege of being the highest enrolling site for this in Minneapolis. So you use these models that they will move around in the cath lab, will help you understand how to modify the plaque, whether you have to do IVL or atherectomy. So just to elaborate on the point of calcium distribution, you'll hear more and more about that. The other concept that, again, we do not get from intravascular imaging, and we're learning more, is the concept of calcium density. So here, calcium density is something that's been around for a while. For those of you that do CT, you know you can just hover your mouse over any area in the CT and you're going to get Hounsfield units. But what's happening is now that people are saying, can we look at how hard is that calcium? And as you can see here, you can get the morphology. You can look, this is a study now from a few years ago that looked at mean density to understand, can I predict the need for rotational atherectomy? And they looked at a number of criteria, and they identified that density was the best predictor for reading atherectomy. But again, how is this evolving? This is evolving where now you can phenotype coronary calcification. So people are saying now, can we get a map of how that morphology of the arc is? There may be patients that have Hounsfield units over 1,000 across the entire arc. Maybe that patient needs rotational atherectomy. Maybe it's just one cross-section. So maybe a non-compliant balloon would be sufficient. So many interesting opportunities there for diagnosis. So there is a plan to do a P5 trial. It's going to be a CT-guided trial focused on severe calcified lesions as compared to IVUS guidance. This is still a preliminary protocol courtesy of our friend Carlos that's leading this trial with James Pratt, but just be aware that this is an area of great interest. Now, shifting quickly to treatment, I think it's no secret that intravascular lithotripsy has really been, has really changed the field of how we tackle calcium in day-to-day practice. This is a publication from J. Sky that clearly shows how there's an increasing, and every time we see an update in this curve, there's an increasing adoption of IVL. This is also what's happening down the pipeline. There is now numerous players in this arena, as you can see, outside of Shockwave and the evolving studies and strong data that since they've been the first in the field, but now there's the Tectonic trial from Abbott, there's the Fracture trial from Bolt, there's the SOLA from Fastwave Medical. So there's a number of approaches that are now trying to tackle, slightly different approaches as the use of intravascular lithotripsy, and we'll hear more and more about this since they're tackling this from different angles. One of those angles that Shockwave has done is to say, like, well, as all of us have had, is I cannot even get my balloon across the lesion. You saw that in my example, how I used the off-label peripheral, but there's now our ongoing pivotal forward CAD trial for a coronary microcatheter-based IBL to try to pretty much what we've done in most cases historically is use laser to create a pilot hole. But now the idea is, does IBL have a role in this? So be aware that there's also now a microcatheter or catheter-based IVL as well trial that's ongoing for this. What else is happening? There's other people that are saying maybe we should do another types of IVL. This is technically considered also IVL, but it's a different type of mechanism. It's called the Hertz contact IVL. As you can see there in yellow, this was presented at TCT last year, the Pinnacle 1 trial. What it does is uses this mechanism of creating fractures by amplified discrete focal stresses. You can see there how it does this. The IDE study showing that this was effective, 98% primary safety endpoint and effectiveness was presented last year. So be aware that, again, this field of treating calcium is very rapidly growing, and there are people that are trying to figure out how to tackle this from different perspectives. Now, OPN has been around now for a little bit, but there's still a number of questions about applications. Our colleague here, Manos, is starting a multi-center OPN registry that will try to elaborate and inform how is this being used in clinical practice. I think a lot of us are using it for ISR, but there's a lot of questions as to whether people are using also a lot for calcium. So with that, I will just say my 3 final points is that I think it's important to understand that there are new concepts in the risk stratification and diagnosis of calcium. A lot of it is with CT, for example, to understand calcium before we enter the lab. And I think the concepts that I want you to remember are 1, calcium distribution, the other one is calcium density. 2, realize that yes, we have all the scores that it's helpful to remember, but I think the present and the future is going to be a lot of AI aids to help us understand some of these criteria of plaque and calcium. And 3, be aware that there's numerous trials that are going to be down the pipeline, so it's a very exciting moment in coronary interventions. Thank you so much.
So, Yader, do you have to leave right away?
I'll stick around.
Okay, because I want to ask on 2 quick questions, and maybe we'll get the panel to weigh in too. So I was impressed that when you looked at the data from Eclipse, which is sobering in the standpoint that there was no different, but when you did imaging versus no imaging, you had better outcomes. And second, and I know this is a sub-analysis, but get your thoughts about this. When you did OCT versus IVUS, in calcified lesions, the OCT did better. So do you have a preference in terms of how you do intravascular imaging with calcified lesions? And can you give us your thoughts? And I'd love the panel's thoughts on that as well.
Yeah, I mean, a lot of expertise here in the panel, but briefly I will say I don't think that the intravascular, that coronary imaging modality, it's a factor. To me, at a practical level in the cath lab is, can you get the catheter across? If you're doing OCT, can you get it across and can you opacify? So again, there's some practical issues. From Illumian, they just published in European Heart Journal their sub-study on calcified lesions. So to your point, same message, showing that in patients with severe coronary calcifications, in those subsets, whereas the original Illumian in New England did not meet its primary endpoint, the one on calcium was markedly positive. So I think the message is that if we do imaging in these lesions and we act on those, and something that I didn't address, maybe I should have addressed, is this issue of now if you look at that, you did calcium fractures, whether you found the nodules and other phenotypes that you can do better for your patients. But I think as long as you do any imaging, I think that's fine. Maybe others can speak.
Poonam, do you want to start?
Yeah, I kind of agree with you. I think it's the supercalcified lesions that we identify with intravascular imaging that's so important, in which case the modification techniques would be helpful. I don't think that visually you're able to really tell the difference. And to your question of IVUS versus OCT, I think imaging either just get good with one technology. I, for instance, use mostly IVUS, and I've never gotten into the OCT, but there are benefits in, there's some situations where we could use OCT, but I personally have used IVUS and I've never had any reason not to use IVUS. So.
Yeah, I agree with Poonam. I think it also depends on where you're working, right? So if you have IVUS, you use IVUS. If you have OCT, use it. But I don't think you have to work within the constraints of the financial situation of your lab as well. So I think people should just get very good at using the tools that are available to you, especially one or the other, IVUS versus OCT, in helping you determine what the amount of calcium is and then modifying your
If I can jump
PCR.
in for 1 second on what you said, because it's important. There are some in this community that's emerging of people interested in using CT for guidance that have said that maybe the CT would be of value in geographic areas that are going to really struggle with access to intravascular imaging, but that CT is available for some reason, and that therefore you can use the CT to know beforehand and get that understanding. So I know that some people feel that that's a real opportunity.
Yeah, and I think to your point, because I was really intrigued when you talked about the calcium density, and that's something that most places have a CT. So even if they don't, so using your CT imaging to help predict the amount of calcium density, I think that would be very useful in smaller labs.
Jada, maybe a sentence specifically for calcium, the photon detecting CT versus the current CT. Your thoughts?
As this field is rapidly evolving on the visualization of calcium and plaque with softwares, it's also evolving in hardware. And so there are now scanners that will, with better precision and accuracy, will reduce some of the existing limitations of CT, which is, for example, calcium blooming. All stents has been historical problems with CTs. So for some, there might be some here at the audience. I think there's a few places around the country. I think Mayo and others have it, that we're getting it until next year. But yes, the photon counter scanner will really reduce some of that blooming artifact and will help us understand better things that have been historically a limitation, like stents and calcium.
One comment about the CT for many people in the audience, I'm sure this is true. I started my career at Minneapolis Heart and was there for a long time, so I was used to high quality CT. There's considerable variability around the United States in terms of what's available and how available it is. I think that with reimbursement, et cetera, I think it's going to get better for everyone, and the ability is going to be better for everyone. Right now, still, I'm sure many people in here do not have the same high-quality CT, for sure.
No, it's an excellent point. I think there's people here from different areas of the world, but if you talk to people from the UK, NICE guidelines have recommended CT as the #1 modality to evaluate patients for many, many, many years. When I meet with my British friends, they will roll their eyes if we tell them that we do functional testing. They're like, what? So I think this is with the guidelines, HACC recommending more CT for evaluation. I think this will gradually shift. To your point, in Minnesota, I feel that there's been an early adoption of CT at a higher rate as compared to other places in the country.
Yeah, so we do a lot of coronary CT, but I want to add something else, and that is even if your patient doesn't have a coronary CT coming to the cath lab, I bet if you go back to PACS, you will see a CT scan done for PE rule out or whatever. And I got to the habit of also for diagnosis and also planning in the cath lab. They're referred to me for cath. Too late to send them back sometimes. Just pull that up. That helps you a lot to see. You can see the coronary ostium, you can see the amount of calcium. Helps a lot and gives you a lot of good information about that patient, and it's for free.
Yeah, just one quick comment. I tend to use IVUS more than OCT. I have OCT available. One of the problems I find is patients with heavy calcification, and especially calcified nodules. They also have chronic kidney disease, a lot of them. So I have not found a good way to do OCT without giving contrast. I don't know if anybody has any ideas on that.
One can do saline-based OCT. Maybe Rajiv and others can speak, but it doesn't pacify the whole deal. But yeah.
Jana, that was absolutely fantastic. Manos just said he's got 2 more talks for you to give, by the way. Just texted us. Okay. Safe travels. What a wonderful talk. Thank you, Yader. So next speaker, we have Dr. Farshad Forouzandeh, who, despite looking only 28 years old, his specialty is PCI in the elderly. Welcome, Farshad.
Thank you so much. I appreciate Dr. Gulati. Thank you, Manos, for invitation. One of the nurses yesterday was we were introducing to each other, and she asked me, where are you from? Like a fellow from where? I was like, oh, I'm not a fellow there. So that's actually a good point. Thank you for staying actually that late. So this is a very interesting topic that is close to all of us' heart. Putting things together. We are taking care of older patients more and more than what we used to. I think the statins are doing their job finally. And this is CVI, so we all learn from cases. So that's where I want to start actually my talk. So this is an 86-year-old male I took care of a few months ago. An array of peripheral vascular disease from neck to renal artery to PAD, the AAA. comes in with left-sided chest pain, weakness, and then eventually a chest pain, shortness of breath, fatigue, to our emergency room. By the way, has a DNR form sign just in his chart. And the troponin comes back 5,000, typical non-ST elevation MI, BNP is high, he's in heart failure, creatinine is 2 above the baseline, and ED before even they call and consult cardiology, they did CTP to rule out there's no PE. Of course, there was no PE, there was pulmonary edema, but the patient got a load of contrast. So we did an echocardiogram, EF 30-35%, has moderate aortic stenosis. So think about this 86-year-old gentleman, how would you approach him, how would you take care of him? And that's, again, something that I'm sure if you go back to institution, probably even last week, you had a similar patient. And this patient group, octogenarians, nonagenarians, they are growing, and they are, keep coming actually more and more. But the interesting thing enough, and many of these data that I get from the survival and all that are from oncology literature, because they do probably a better job than us looking at these things. So if somebody gets to 80, they have on average 7 to 9 years more life expectancy ahead of them. And of course, it really depends on the patient health condition, lifestyle, social factors, and all that. And I can submit to you, if you don't think of it, from now on, you get the certificate. You're a geriatric cardiologist. This patient group is, increasing, and by the 2034, which is, a few years down the line, we have more people who are 65 and older than, younger people than 18 years old. So we are all in this together. Nobody can say this is a, problem for a geriatric cardiologist. So it is all of us issue. And we learned about a lot of cheap cases, complex cases, and just having an advanced age, which you can put the cutoff differently. I think nowadays we usually use 75. By itself makes a case to be a cheap case. So you have to think of it that, I'm approaching this non-ST elevation MI as a cheap case, so do a whole assessment and, put that into consideration. And the whole assessment is, to just make it summarized and easy, is to look at this geriatric cardiology framework, which, being honest with you, there were hours of discussion, meetings to go through this, to put together the medical condition of the patient, what medications they are on, their amount of mobility, frailty, which I'll talk a little bit about later, and what is their mentation and cognition, social environment, and at the center of everything, what is really the most important thing to that patient? Is it longevity? Is it quality of life? Is it taking less medication? Is it being able to spend more time with their family? I had patients above 90 years old, 97, 98, and all he wanted is to live until fall, which is going to be the graduation, or is going to be a ceremony for that great-grandkid. So it's really important to keep things in mind, what is important for that specific patient you are taking care of. And we take care of these patients with acute MI, frequently in the cath lab, and if you have a younger patient, they usually breeze through that. You put the stent, even it's anterior STEMI. Sometimes if it's early in the morning, you kind of debate yourself, the EF is okay, maybe I should do same-day discharge. We don't do it yet. We do next-day discharge many times. But when you're taking an older patient with the same anterior elevation and my kind of phenotype, usually there's a chance for them to go through many, bumps in the road to be able to get them to where they need to be. So that's the difference between the young and older people. And the aging heart is less forgiving. So God forbid you have a complication, something bad happens in the cath lab. It can happen. So for an older patient, older heart, there's going to be less forgiving situation. Having said that, people would say, CAD in older adults may not be as symptomatic. Let's just try medications. That's not true. When you look at the numbers, as people they get older, the prevalence of symptomatic CAD actually increases. So younger people may present more with ACS. And the non-ST elevation MI death, which is very frequent in this patient population, is not a small amount. It's about 45% when somebody gets above 90. So about half of them in 1 year are going to be dead if you don't do the right revascularization and medication. There's not a whole lot of data in terms of PCI, again, in this age group, but if, again, I try to dig in a lot in the registries and all that to put this together. But for a 90-year-old, if you do a PCI, the mortality in 1 year is 20% versus 45% if you don't do nothing, just medical therapy. So it's still, chances are much better if you do the revascularization. Unfortunately, this patient group is not well represented in clinical trials and also even in registries. So that's the paucity of data we have in this age group. And that actually makes things a little bit more difficult for us to decide what to do, and that's where your experience and being holistic about this whole thing really is important. But at the end of the day, to decrease the patient cardiac mortality, to improve cardiovascular well-being, quality of life, angina burden, you should consider PCI when appropriate in this age group, but you need to do it as safe and effective as you can. Unfortunately, again, many of these patients, they come in with true ACS with no clear contraindication like active bleed or really bad AKI. Many of them, they don't get to the cath lab in a timely fashion, even up to 48 hours. So that's the situation that we have with this patient age group. But I want to think about it as like, what would you do pre-procedurally, during the procedure and after procedure, which might be a little bit more in detail than what you would do in a regular actually PCI. So pre-procedurally, you want to have a comprehensive assessment. You want to know the patient. You want to know their medical history, what medications they're on, the frailty, which I give you a couple of tools to use, which medication, again, anticoagulation, antiplatelet, very important, they're on. And for the informed consent, one thing that I learned a lot is to make sure the family are there, if they have family or friends, or put them on the phone, and make sure you speak either loudly or slowly, or both. If need be. So make sure that you are really communicating with the patient, they understand what you are consenting the patient for. Don't assume it's going to be like, they're understanding you. Try to have them call and, tell you back what was the consent about. And then optimize the situation as much as you can. Choose the right antiplatelet regimen. I sometimes, for this patient group, use clopidogrel over ticagrelor in terms of antiplatelet, especially if they're going to be on some sort of anticoagulation like DOAC for another reason. And optimize their renal function if they need to help with that. And then do not rush to these procedures. Again, I'm advocating to do them when appropriate, but not in rush as much as you can, and understand their cognitive status in terms of acute situation and in terms of if they do have some dementia, because all that, especially when you are going to the procedure, that plays a role in terms of your sedation and how you choose. So this is one of the frailty scores that is probably familiar to you, because this is what NCDR uses. And it goes to our scorecard or whatever, and it really depends on how the patient is doing in their daily life. So there's no way you can get this information without talking to the patient and their family and understand what they do on daily basis. This is actually from TAVR. The people, our colleagues in the structure, they're very familiar with this. One thing I would advocate to use more frequently, which is very easy, these 5 chair raises, how many times they can rise from the chair, and is it going to take them more than 50 seconds or not. If they can do it in less than 15 seconds, that's actually pretty good in terms of mobility. And also if you ask the question of about 1 flight of stairs, if they can do that in terms of mobility, it is good. But remember, frailty is a syndrome. So like any other syndrome, it has multiple physiological systems that can be involved. So it's good to have multiple aspects of the patient to be assessed to decide if the patient is frail or not. And remember, that's going to be on a spectrum. It's not a plus and minus or black and white. So going back to the procedure, in terms of the sedation, you want to tailor it. One thing I really learned a lot, using things that like music, trying to calm the patient down by just sometimes talking with them, and sometimes some people, they want to pray. Let's, give them, a little bit time for them to pray or whatever that makes them more comfortable. And be very careful not to over-sedate them, because that can happen, especially with the elderly, really easy. And then don't ignore any cognitive impairment on the baseline that they may have. We talk about radial access, in multiple, sessions, but this is a patient group that I'm going to show you a few cases. You'll see it might be a little bit more challenging, but they probably get the most benefit out of it. So try to be radial as much as you can. And if you have to go femoral, especially if you have to use hemodynamic support, please don't do that without understanding with the CAT scan or whatnot what's going on in the groin, and if there is a possibility for a good femoral access, especially in terms of hemodynamic support. And during the procedure, in terms of the contrast and renal function, of course, be as minimized as you can, hydrate if that needs to be, and do as less as possible. And don't ignore contrast allergy. Once in a blue moon, we see patients with no history of it get into trouble, but most of the time there is some sort of use, especially when people, they get by this age, they know if they have allergy or not. Post-procedurally, closer monitoring, again, than usual actually patient that you do. be very cognizant about their pain level and address it appropriately. Again, not too much, not too little. And encourage early mobilization. In multiple, surgical, non-surgical literature, that actually helps a lot with these patients. One thing in terms of their discharge, please do not rush it to discharge. I know all of us in hospitals are a little bit, forced to get the patient out, but these are the patients that you may want to keep them one extra day to make sure that they are in the best shape possible. And something we do in our system pretty frequently is meds to bed. So we provide the medication to the patient before they leave the hospital for the next 3 months from the retail pharmacy. So going back to this case. So this case comes in, this gentleman, first of all, we did have some conversation about the code status and all the other things, what are the risk benefit. And I actually sat on the patient for good probably 3 days, trying to, first of all, he was so short of breath, he was on BiPAP, he was in crackles and in fluid overload. So we start diuresing him, again, gently enough so that the kidney function doesn't get worse. And he does have moderate AS, so we have to put everything into account. So diurese him after a few days, creatinine getting closer to his baseline, kind of marinating with, P2Y12 inhibitor, in this case Plavix, give him heparin, and after appropriate consent, bring him to the cath lab. And again, not very unusually, you see all this tortuosity in the subclavian on these patients. So we go in and, do our diagnostic cath, and this is what he had. So as you see, distal RCA, very focal lesion, probably the culprit for his non-ST elevation MI. And this was his LAD, again, mid-LAD lung lesion. We can call it double culprit, but probably both of them pretty tight. So now I want to get my guide down, and the guide comes in and stops right close to where the actually arrow is there. It doesn't want to cross and go down. So something that I've learned, and again, dealing with older patients not infrequently, I found it helpful, is to use a 5 French diagnostic catheter, like a JR4 most of the time, and use that to telescope and get your guide catheter down without losing your actually wire access. So we did that for the right. It was a simple PCI from that point. Just one stent there, again, minimal in terms of the radiation and contrast. Take care of the LAD the same way. So use the EBU, use the JR4 125 centimeter in it, get it down, fix the LAD, and that was the result we got. We went home in a day or two after that. Everything was fine. He comes in, he sees me in the office now for 7 months. So his last plan, I saw actually 2 weeks ago, was to do a road trip from Cleveland to Vegas. And he said that I'm going to stop every 600 miles driving, and I think that is safer than taking a flight. So we had a nice conversation that maybe you don't want to do that. Let's go with the flight. So that was a conversation that I've been enjoying their life together, no problem. That's another lady. I did take care of her about 2 weeks ago now. 78-year-old lady comes in, mild cognitive impairment, not fully demented in terms of the diagnosis, but definitely slow. So I had to talk with their family and husband about the procedure more. EF 35%, mostly anterior wall hypokinesis, short of breath, and they come in. And this is the radial approach. We advocate for it, but sometimes you get what you may not wish for. But anyway, so we go in with the Tiger catheter, take the initial angiogram, and if I can go back there. Oop.
Have no time here, so sorry. Maybe we should skip this case and maybe let's just go to discussion so we have a little time to discuss. It's a great point you were bringing up. So,
all right. So yeah, we fixed. Then this was a 90-year-old with the ST elevation MI that was denied, in another hospital because of her age. And we said, let's just bring the patient in. And she was pretty actually active, independent living. So I decided to take her to the cath lab.
a great point to discuss.
There we go. So I work in South Florida, so this is pretty much my population. One of the hospitals I used to work in, the average age of the hospitalized patients was 82. And a few months ago, I was talking to you earlier, I had a patient who was 99, came in with anterior STEMI from nursing home and had dementia. So this is something we see often. If you, obviously if they come in with STEMI, there's not a whole lot of time for you to do a whole lot of digging to the chart or talk to the family. But I think the slide that you had on what to do pre, that's very much on point. This is what we do for every one of our patients who are in their 80s, and we have quite a few nonagenarians as well. Super important to have set the expectations with patient and family members, frailty status assessment, EFT tools, we use it all the time for TAVRs. I haven't used it a whole lot for PCI, but that's a great point. Futility of care sometimes has to be brought in discussion. Is there any point of doing anything for some of these patients who really don't do a whole lot? And then the point that you raised about figuring out the family situation and patient's memory status is super important. There's been so many cases that we thought patient's memory was great, and come to find out a month after discharge, patient's not taking her to DAPT, for example. So figuring out who's going to be the family member who's taking care of the patient, who's going to be with them, and make sure that somebody's responsible for a patient get DAPT is very, very important. But sometimes age is just a number, but sometimes it's not. It is really truly reflective of a patient's health status.
Yeah, no, excellent. One comment, we just published a paper of over 300 over 90-year-olds with STEMI outcomes, and I think there's a couple take-home points. One is still across the country, people are avoiding that, and so only 15 to 20% of patients are actually getting it, even though data shows that it benefits. So, but there are nuances in it for sure, and one of the ones that was clear is a patient that was in a nursing home to start with did really poorly. So I think this is something you should be thought, when they're subacute, you have time to do all the things that you just talked about. When it's a STEMI, it's much more challenging. Yeah, all right, and so in the interest of time, we're going to move forward, and I think our next talk is what is new with arterial access, and this is Mazen Abu-Fadel.
Perfect. Thank you, everybody. Thank you for the invitation. Short answers. Not much new these days with arterial access, but we're going to present some studies and something that has helped our institution a lot. I'm going to just give pointers. I think this would be good, but I'll start with a couple of meta-analyses, and this is the first one: efficacy and safety of distal radial artery access versus the proximal radial artery access for the cardiac procedures. So numerous trials have shown that the distal radial artery access would be helpful, decrease complications such as radial artery occlusion. The approach may be a little bit more technically challenging to get access, so there's been a number of randomized and non-randomized trials to look at these two areas of access in the radial artery. So in this meta-analysis, it was a number of randomized controlled trials, came down to 8 randomized controlled trials for patients, 21 randomized controlled trials included. Over the intervention was the distal radial artery, obviously the competitor was proximal radial artery, all adult patients, and the total number of patients was 9,500 patients. The primary endpoint was to look at radial artery occlusion at 24 hours. And then these are the secondary endpoints, which are the typical endpoints we look at when we're looking at access trials: puncture attempts, success for the access, success for the procedure, bleedings, hematomas, time to hemostasis, fluoroscopy time, etc. So when you look at the primary outcome, it actually did favor distal artery access for the radial when compared to the proximal access. When you look at the secondary endpoint, and I know this slide is a little bit busy, but in general, it was a mix and match of everything. The success rate of puncture was significantly lower in the distal radial artery. It's just a little bit difficult to get it on the first try. The distal radial artery significantly more puncture attempts to get, even with using ultrasound. The caveat is not all these studies used ultrasound, so only 4 of these 21 actually did use ultrasound most of the time during the study. Crossover was also more with distal radial artery, and then some things were compatible, like the procedure time, radial artery spasm, or fluoroscopy time. So it was a little bit mix and match, even though the radial artery occlusion did favor distal radial artery. Second one I'm going to talk about a little bit is the dedicated sheetless system versus the sheet approach for radial artery access and procedures. And this is again a meta-analysis done. Total 6,380 patients in 8 studies. And again, you have either dedicated sheetless systems or sheet-based system. And just summarizing the outcomes here, when you look at access-related efficiency, really the sheetless was a little bit better. Radial artery spasm was better, and access site crossover was also better. When you look at the safety and the key procedural metrics, they kind of were equal, so there was not much different between the two. All right, so this meta-analysis really supports that sheetless approach is as safe and effective as the traditional sheet approach, and the bleeding procedural success along with significant reduction in access site crossover and spasm. Perhaps this is the one that I want to spend a little bit more time on and tell you a little bit about our practical experience with it. So we are a very high volume cath lab. We do 50 to 80 cases a day in our, and we need the turnover time to be very good. And we've always had issues, thinking going to radial is going to be like time saving, but actually we noticed that getting hemostasis, especially after PCIs, was one of the biggest hurdles in this. So we know there was some data STAT2 trial and stuff that came up, whether you use hemostatic patches and how you use them would help in really decrease the time to hemostasis and discharge. But this ARCH2 trial was really helpful when you put all the data together, kind of allowed us to change our protocols, and I'll spend a little bit of 1 minute on that with you guys, just to maybe you can do the same at your institution. So this study was an open-label randomized controlled trial, single-center prospective, and it's full all-comers for radial, whether it was intervention or whether it was diagnostic, as everybody was there. And they separated the patients into 3 equal groups. The first group was to get regular hemostasis with 2 hours band on the radial artery, the regular way. The second group was the same with a 1 hour radial band. And the third group was to use a hemostatic patch. Now, I have no conflict of interest here, but it was the stat seal because for purposes not to be discussed now, the way it achieves hemostasis is actually a little bit better and superior to the other hemostatic patches. So this is the one that's been used and studied in this population. And again, it was 1 hour with a hemostatic patch. And the patient populations were kind of the same, elective versus urgent. PCI was around 50 to 55%, so a good group of people got full anticoagulation. This is important. And the ACTs were, of course, kind of compatible. The primary outcome was failure to achieve hemostasis at the specified time, which are 2 hours versus 1 hour. Secondary outcomes included total time to final hemostasis. So if they go beyond the 1 hour or beyond the 2 hours, what was the total time? And the other things that we talked about. But the third one was the one that really was good, delay discharge or delay to transfer from the recovery room to the floor or wherever your patients go to the hospital. So the upper 3 pictures show you how we usually do it, just a regular 2x2 gauze with a tegaderm, and then you remove the sheet and you inflate the TR band or whatever band you use. The second one is to put the stat seal, allow a little bit of blood to kind of activate the stat seal, then put the tegaderm over it, and then the TR band goes over the tegaderm, because this is important. And here's the difference. The patient who got conventional 1 hour, really, it took them median almost over 2 hours to get hemostasis. So these are the patients, you deflate a little bit, you come back, you have to put more air, and they're bleeding, and they come and go. The ones that were there for 2 hours really had 166 minutes, and the one that had the stat seal or the hemostatic patch did good with only 72 minutes. As far as the bleeding or radial artery complications, there were really no differences. As far as discharge, you can see you can save a lot of time discharging patient or to transfer patients to the traditional care floors or unplanned overnight when you do late cases. So this was important. So the use of hemostatic dressing allowed for more rapid, consistent, and safe hemostasis, reducing nursing care requirements and incidence of delayed discharge. And the way we've adopted this is you allow the blood to activate the patch. As I said, you inflate the TR band to 10 cc's, Different bands need different inflations, so we don't use TR band because we are such a high volume center. The difference in price makes a lot. So we have a cheaper band, so we have to adjust for that, how much air we put in it, and then deflate 3 cc's at 20 minutes, and then deflate fully at 1 hour. Keep the band on for 30 additional minutes without any air in it, and then what you do is you remove the band, keep the tegaderm with the stat seal under it, discharge the patient home, let them remove it the second day when they are in the shower or something. That's all I have to say. I'll tell you, our nurses love this, our patients loved it. We have been able to decrease the amount of time patients stay post-procedure, and the turnover rate has helped. We actually saw exactly what the randomized controlled trials showed. There was no increase in complications. So I don't know how many of you actually do this, but I just wanted to bring it up there because in high volume cath labs, it can help a lot. Thank you for the opportunity.
Mazen, thank you. We'll have comments from the panel. I just want to give a counterpoint on that hemostatic patch. At least in our single-center experience, we have seen a fair number of pseudoaneurysms that wouldn't have been picked up by the short duration for randomized trials, particularly in patients with DOACs. And it kind of makes sense, I think, with the mechanism of action. So just a little counterpoint to that, and be interested to hear your longer-term experience maybe in the future. Stefan.
Just a question. In the trial, do you remember if they were, or in your practice, do you make any attempt to do patent hemostasis or not?
Yeah, so we do patent hemostasis. We did. Now we don't even check for it with this new protocol.
Okay.
But we did on everybody else before.
But with this protocol, you just follow the protocol, occlusive, non-occlusive, you don't care because it's going to be 1 hour, that's it.
Correct, and most of the time with the 10 cc's, it's not totally occlusive when you check it, but it has been enough. And again, we don't have long-term personal experience, but I can tell you this is only for PCI patients in our institution because of the volume of patients we do. Everybody that does diagnostic, the nurses take it out manually 20 minutes and they go home. So this is our experience is only in PCI patients. It's not even in diagnostic patients. Diagnostic patients don't get a band, don't get a stat seal, don't get anything. No.
I mean, that's a great technique, and we'll look into it. One other thing that we found useful is to use a proximal band a little bit more liberally than maybe some other people may do, to just have a second band if there's any concern with a lower amount of air in it, and that helped a lot.
There's a question on the audience there.
Yes, sorry.
Yes, I can tell you from a nursing perspective, our attending physician, we have one main physician, she does exclusively distal radial with a TR band, with a stat seal. We've been using it for almost 2.5 years, and I can tell you, it's amazing. We usually have patients who are diagnostic, that band's off in 45 minutes to an hour. If it's interventional level heparin, it's 60 minutes. They go directly to the floor from the lab. They don't even stop in recovery. And that's been standard in our hospital for almost 3 years. And now it's department-wide, now that she's our department head. It's fantastic.
Excellent.
10 out of 10.
Do you know, just because you have more experience than us, do you know if any of your patients get pseudoaneurysm, or maybe you don't see them? Because that is a concern.
It's rare.
But if you have 3 years experience, that's...
Yeah, they, even in ICU and CVCU, when there's a problem with the band, they call us. We come to the bedside to evaluate. It's so rare that we ever have that problem, and usually we just put on a second TR band. But it's very, very rare, like maybe once every
sometimes
4
they
to
do
6
show a
months.
few days.
Yeah,
So we'll keep an eye on this.
And I'll tell you, patients are more compliant when they have that stat seal on. For patients who constantly want to bend their wrist, it keeps them straight. So 10 out of 10 would recommend to anybody.
Thank you for your
I've got to say, the
experience.
nursing perspective is so important here, right? I mean, really,
Our
they're the
nurses
ones
have
that see
loved
the
it,
issue. So
both on the floor and on the unit.
maybe a quick snapshot. We're going to have one show of hands. I know everyone here does radial here, so maybe hands up for those that do the majority of your radials from the distal radial access. Show of hands. Okay, and standard radial access. Okay, so probably 1 to 5, right, distal to standard. Okay, very good. Arnold.
Yeah, just another plug for the StatSeal. We did the STAT2 trial. 400 patients came out a little earlier than ARCH trial, but it actually showed some reduction in bleeding endpoints, because if you try to use the 1 hour protocol for the TR band alone, then you get more hematomas naturally if you're trying to release it that early without the StatSeal. The StatSeal is really qualitatively different because of its mechanism of action, different from the DStat and other things that we used in the past. And so we've been dumping it on everything that might be oozing, whether it's a venous ooze or perclosed ooze, and it turns out to work, and it just helps you seal it up and reduce your time. So I think whatever you use it for, try it on everything, and it's quite effective.
And I have to give Arnold credit, because we started this after I heard Arnold talk about it in CRT meeting in February, and I went back down and I said, guys, we need to change our protocol, and we did it. And so far it's been good. So really it came from a meeting like this where I learned about it. So
how does it work, Mazen? So for people are potentially asking, how does this work? Why is this different than the other patches?
It is different, and maybe Arnold has more information, but the potassium ferrate, that the compound that is, is in the StatSeal, allows you to have the seal, and then it sticks to that seal, and it does not allow more oozing. So Arnold, do you want to?
Yeah, I mean, the term was agglomeration. It actually dries out the blood. It doesn't try to activate the coagulation factors. It's solely independent of the coagulation cascade. And the StatSeal manufacturer, they have a nice video which shows that you can pick up an apple with it dried on to the top of the apple, and you can't do that with the DStat or any other of the KLN compounds. So it really is qualitatively different. Just give it a try. I would caution that if you use it without the TR band, a different type of band, you need to adjust the thing. When the TR band was on short supply, a number of places tried it, both MGH and Mayo, and they had some more hematomas because the other bands don't necessarily apply the pressure equally.
Yeah, we put 3 cc's more. That's what worked for us, because we don't have the TR band.
We have a question or comment from the audience?
Yes, please.
Hey, Zach Russell. I'm at Baylor Dallas. I'm a primary radial operator as well, and we do have StatSeal. How much, and I hear you on the pseudoaneurysms, I wouldn't say we've had an uptick, but it is noticeable. To play devil's advocate, and we use StatSeal in all cases. How much do you think it is that you're just getting a larger area of compression versus the actual chemical reaction?
I mean, the bands did not change. I think the area of compression may be really related to the band more, because the band covers, at least the bands we use, covered the whole surface area of the StatSeal. So I don't see larger area of compression, at least from my experience.
I think just one sort of word of caution is that we have these competing things. On the one hand, we have these well-conducted randomized trials that show the more blood thinners you give, the fewer occlusions, right? So the latest randomized trial was 100 units per kilogram of heparin for diagnostic, kind of a lot with our bigger patients. And on the other hand, we have this competing business of trying to get rapid hemostasis. They're not going to go together well. And if we really want to understand the impact of these hemostatic protocols, I think we need 30-day follow-up for occlusion and other complications like pseudoaneurysm. I'd be a little cautious about just using these discharge metrics to make a wholesale shift. At least that's my perspective. We've got time for one more question or comment from the panel or audience. Wonderful. Mazen, thank you so much for a fantastic overview of the latest in radials. Next up, we really have subject matter experts. What an incredible session here. So we have, of course, Jacqueline Tamis-Holland, who everyone knows is going to talk about advances in PCI for STEMI.
Hi, everybody. I'm so excited to be here. Thanks, Manos, for inviting me. And thank you for letting me walk the runway. I feel like a model. So I'm going to be talking to you about advances in PCI for STEMI. So we've really made some incredible progress in the last 45 years. It started in the 1980s with DeWood, when he first showed that coronary STEMIs were due to thrombosis, presumably from plaque rupture. And this paved the way to us being able to do fibrinolytic studies and then later primary angioplasty to treat MI. In the 2000s, we started to implement systems of care for STEMI. And what we did was we were really focusing on treatment times and how percentage of patients getting reperfusion and how quickly we can do it. We did this great. We've really improved our treatment times. But now it's time to focus on other things. So I think from now and beyond, we're focusing on things that we really hadn't thought about before, which is decreasing the infarct size and other things in terms of preventing restenosis and problems in the future. So when we talk about advances in PCI, I think what I'd like to talk about today is identifying the occluded artery, tackling reperfusion injury, managing large thrombus, and perfecting the PCI procedures. These are things that, honestly, we don't have great data on, so I'm going to just sort of put this out for more food for thought so we can have some discussions, but there's really a lot of work we need to do for the future. So let's start with detection of the occluded artery. So I work as a quality person for STEMI, and there's nothing, we have great data, 100% door to balloon time in 90 minutes, great first medical contact to device. But what about those patients who come in, they don't quite meet the STEMI criteria, they have a door to balloon time of 12 hours, but the truth is they fall out of our metrics, so nobody really worries. But these are the patients with occluded arteries that really had their occluded arteries for 12 hours, and we should have recognized it earlier. So I think nowadays what we really need to do is to understand ways to identify patients with occluded arteries. And we shouldn't be talking so much about STEMI. We really should be talking about who is the patient with an occluded artery who needs urgent intervention. So there's lots of AI models looking at occluded artery algorithms and designed to detect occluded arteries. So this is one example. Tim Henry can tell you more. This is the powerful medical example. And what it did was it took thousands of patients with ACS, suspected ACS, who went to the cath lab. The computer model looked at the EKGs and then looked at the endpoint of an occluded artery or a flow-limiting stenosis in an artery. And they were able to show that it outperformed the usual STEMI criteria or expert EKG reads better than either one of them. There was a sensitivity of 94%, specificity of 80%, and an area under the curve of 0.93. So really great models to detect occluded arteries, and I think so that's what we need to focus on now is identifying the occluded artery. What about reperfusion injury? So reperfusion injury is the paradoxical worsening in myocardial damage resulting when you open the artery. And we all get these great PCI results, these great epicardial reperfusion, but we really don't get good results sometimes in some of our patients despite great door-to-balloon times and so forth. And that's because the reperfusion injury is a result of microvascular obstruction, microvascular vasospasm, edema, and intramyocardial hemorrhage, and we can't always predict that. Of course, longer delays and worse TIMI flow post-procedure predicts it, but not every time. And what we really need to do now in the future is to focus on reperfusion injury. So there's been a ton of studies looking at ways to tackle reperfusion injury. The only FDA-approved agent we have is the SSO2, and it has been shown to decrease infarct size compared to usual treatment, although there's little in terms of long-term outcomes data and real large studies on outcomes data. There's been some studies. We know the door to unload pivotal trials coming out, and that'll help to understand whether it's going to decrease infarct size in patients with large MIs getting an Impella device. We also know that there's the IPOST study, which is looking at ischemic post-reperfusion, post-conditioning. And then we also know there's studies looking at mild hypothermia. All of the other things really haven't shown any benefit. And honestly, I'm not here to tell you about a great therapy we have now, but this is the future. We're hoping that there'll be something that can decrease reperfusion injury. Sorry. So those are the things that are on the pipeline. What about tackling large thrombus burden? So I was privileged to be part of the STEMI position paper looking at management of STEMI in the cath lab. And it was interesting because when we went ahead and we talked about what do you do in large thrombus burden, nobody had the perfect answer. We talked about this, everybody had their little recipes. You use intracoronary vasodilators, deliver it to the distal site. There was, of course, aspiration thrombectomy for bailout thrombus. And of course, there was intracoronary IV GPIs or intravenous IV GPIs. But nobody really had some great answers. Some people even mentioned potentially letting it marinate, just open up the artery, get better perfusion, sit on it for a couple of days, and then stent it later. But it's the Achilles heel of STEMI, and we really don't have an answer right now, and I'd love to hear everybody else's thoughts about what you would do, but when we have these situations, we try everything. We throw the kitchen sink at it, and we don't always have a perfect solution. The attractive trial is actually an attractive, interesting idea. It's going the pendulum the whole other direction, which is going back to lysis, which we haven't seen in years. But it's a concept doing intracoronary thrombolysis compared to aspiration thrombectomy for patients with large thrombus burden. It's going to enroll 2,500 patients. It'll look at MACE outcomes at 30 days, 6 months, and a year. And maybe we'll have some more interesting information about what to do with large thrombus burden, but right now there's not such great solutions. Well, what I think we also need to do is talk about perfecting our PCI techniques. So let's start with intravascular imaging. And the reason why we want to perfect our PCI techniques is, of course, we want to get a good result, but we want to get a good long-term result. So the ACS guidelines give it now a class 1 recommendation for intracoronary imaging in patients with ACS. Interestingly, they focus on patients with left main disease or complex lesions, but I personally use it in all my patients. I think it's really important. Just the other day, we had a case that had, a pretty good result after a 2.0 balloon, and I just wanted to direct stent it because there was some thrombus in there. And going in with an IVUS catheter, I was able to size my device and also just direct stent it, knowing there was no calcium and I'd get a good result. So I think we really need to use intracoronary imaging. But I would say to you that in the STEMI population, I think it's interesting because despite the class 1 level of evidence A recommendation, there are no randomized trials, large scale, that are published specifically on IVUS imaging in STEMI. And so despite the fact that I use it, I do want to say that there is some randomized data on the way, the Denami 4i STEMI, not to be published until 2031, but they'll enroll 2,500 patients and look at the role of intravascular imaging in STEMI patients. And this will be the first large trial in STEMI patients. And finally, drug-coated balloons, I think, are something we need to start considering. We talk about leave nothing behind. Of course, the old days, we were concerned about not stenting because we wanted to seal the plaque for STEMI. But in actuality, now that we have drug-coated balloons, we have excellent antiplatelet agents. The likelihood of acute closure after a STEMI is extremely low. And so the question is, should we be using drug-coated balloons? There really is no data on that. There's some real-world registry data from the Japan PCO outcomes looking at 1-year outcomes in patients with ACS. And they did a propensity score matching looking at drug-coated balloons compared to drug-eluting stents and demonstrated no difference in terms of signal for harm in terms of all-cause mortality or non-fatal ACS. But if anything, maybe a lower rate of major bleeding with drug-coated balloons. So something to think about. Again, this is observational data, but just something to think about. Going forward, the Copernican trial will look at about 1,300 patients and randomize them to drug-coated balloons or drug-eluting stents in STEMI, and the primary endpoint will be driven by MACE at 12 months, so hopefully we'll have some more information. So to summarize, the future focus in STEMI care is on reducing infarct size, strategies to improve and manage thrombus burden, and ways to make our STEMI PCI procedure better so we have a reduction in longer-term outcomes. So we're not there yet. We've come really a long way, but we still have a lot more to learn. And I'm sorry if I disappointed you because I didn't give you any new updates on what's happening with STEMI. I really sort of gave you an amuse-bouche for the future about what we're going to do. But thank you.
All right. Jacqueline, that was superb, and it really highlighted a lot of the areas that we're doing. We've got some time for discussion. I'm going to have 3 quick comments. First of all, for everybody in the audience, pay attention to your study data, because what we really know, we just published in JAMA 2 years ago that shows how we're doing in the United States is not that great. And what we've done is had some slippage. And so, for example, patients who present to non-PCI hospitals, only 17% of patients in the United States are being treated in time in less than 120 minutes. So there's a lot of room for us to make our own STEMI systems better. That would be number 1. Number 2, I think this issue about microvascular obstruction is a really important one. And for anybody that's interested, has a large STEMI system, we're starting a trial later this year that immediately after following an anterior STEMI, we can determine whether you have MVO or not. And if we could determine that, and you knew that 50 or 60% of anterior infarcts had STEMI, maybe there would be better uptake of SSO treatment, because I really think we're under-treating people from SSO. And I can tell you, my own institution, we can't get it through the administration. So I understand the challenges of it, even though there's benefit from doing it. But all right, there must be comments, because you covered a lot.
Yeah, I'm intrigued about the intracoronary thrombolysis. I think that will be very interesting when the results of that trial come back, the attractive trial. So I'm looking forward to that.
Yeah, I think it's interesting. I mean, we even in the STEMI document, I think we had intracoronary thrombolysis as one of the options on the original figure, and then everybody's like, we just don't do it. So we mentioned it in the text, but nobody really does it. So it'll be interesting to see, and I think the bleeding risk with the radial access and so forth is a lot less, and of course it's focal. So it'll be interesting to see the result.
I just want to make a comment. I agree with you. I use pretty much 99% IVUS, and in particular STEMI patients, I think it's been very helpful. A lot of times when we get no reflow from STEMI patients, at least we used to a lot more, was putting an undersized stent and post-dilating it. You put a stent in, you get good result, and then you go and post-dilate to optimize the stent, and next thing you know, you cheese great stuff down there. So getting an artery opened up with a small balloon, perhaps dollering it in, and getting an IVUS and then putting the right size stent in the beginning, it seemed to have anecdotally made a huge difference in reducing risk of no reflow for us.
Yeah, I see that a lot, when it's the post-dilatation and the aggressive repeated dilatations that matter.
We IVUS all of our infarcts, but I think the areas that have potentially the biggest bang for our buck is, one, recognizing EKGs that aren't recognized by our ED partners or other people sending patients to the lab, because A, we miss numbers of those, and we review those every month and re-educate our cohorts. And two, there are plenty that come in besides the ones that meet criteria to come in and have occluded arteries, and we had no way to know that, except potentially the troponins come up and the patients have continuous pain, and then hours down the road we wind up taking them in. So that's one big area of bang for our buck. But the reperfusion injury piece is a major issue for us too, because some of these patients, you come in, you get primary PCI quickly, and they come out without really resolution of their ST elevation. And you know they're going to do poorly, but despite the fact that you give IV vasodilators, or sometimes you may put a balloon pump in them, for which there's not the world's greatest data, there aren't that many other things you can do. And that's another area I think we really need help with.
Yeah, no, I agree.
I'll echo that. We have a big experience with the companies called Powerful Medical, and the device is called Queen of Hearts, and they have breakthrough therapy with the FDA, a breakthrough designation with the FDA, and should, if things go well, should have FDA approval before the first of the year. And it's, for those of you out here now having a lot of experience with it, incredibly good at doing two things: decreasing your false positives and increasing your pickup of sort of STEMI mimics or borderline cases. And we've been very impressed with it. It's incredibly easy to use, and I think it'll be especially valuable in non-PCI centers, for example.
Yeah, no, exactly. I think it's really like the EKG experts, the cardiologists can read it. It's for the EMS, for the cardiology fellows, and for the EDs to have that. And that study I showed you was Powerful Medical data. Yes.
Going back to your large thrombus burden again, I think Dr. Gulati and I went in a session yesterday where people gave different opinions as to what we were doing in terms of when a patient comes in with large thrombus burden. And I think you outlined a couple of them. I wonder what the audience is doing in terms of what patients, when they come with a large thrombus burden, are they doing aspiration thrombectomy or, so I'd like to figure out what the audience is doing.
Yeah, I think I'll make a comment on that, on the large thrombus thing. Earlier, I would not use any aspiration techniques because of the trial, but now, there's waiting, and I've started using penumbra, and the procedure goes quickly. I don't know if there's any data related to time and benefit of finishing the procedure sooner, but I've seen a huge difference between just manual aspiration and using the penumbra device. That's just one, but I've seen a huge difference. I don't know how it is with other people. And then I also wanted to make one more comment is when I was at UNMC, Tom Porter did sonothrombolysis for LAD STEMIs. And though it didn't decrease the size of the infarct, it did improve the LV function measured through MRI before and after.
There was a question from the audience about SSO2. If you don't mind, I can give me a brief overview because many
sure.
people have heard what SSO2 is.
Oh yeah, sorry. And I'm sorry I went through that whole reperfusion injury. I gave this talk last year. I was trying to change it up a little. But so SSO2 is a device where you literally put a catheter down and it infuses supersaturated oxygen blood. And so what it does is it's almost like a forgive me if I'm wrong because I don't use it personally, but like a catheter takes out the blood from one sheath, so you need to put a second sheath in. So it takes out the blood from one sheath, supersaturates it with oxygen, and then delivers it back, and it'll go down the artery, infuse down the artery. And the studies have shown a reduction in infarct size, and compared to historical controls, it showed a reduction in clinical events as well. So really great data. I think that the problem is that you have to keep the patient on the table for an extra hour after the procedure. And yes, it's an hour infusion, and you also have a second sheath. So, I think that those are the downsides, and that's what Tim is saying, and I think it's really important. If we could recognize the group of patients who are at risk for microvascular obstruction and, myocardial damage, those are the ones who would benefit the most, and then maybe those are the ones you'd sit the extra hour and use it for.
Yeah, and I think the places that are doing it well are getting reimbursement. You actually get for the hospital and for the physician, get double the reimbursement of what you do for the regular PCI. So theoretically, this can be a good thing, but it's staying an hour extra at 2 o'clock in the morning. It's a little more work. But if you knew the 60%, because the patients who do poorly are the patients who have MVO. And if you could identify them acutely, you would go the extra effort.
Jacqueline, the final word is going to be with you. I'm going to put you on the spot. Door to unload. Is it going to be positive or negative? One word.
I actually think it's going to be positive, but counterbalanced by the secondary endpoints of increased vascular events. And remember, while it's a clinical trial, outcomes trial, it's looking at myocardial damage, right? So it's not looking at hard outcomes. So.
Well, it's been a fantastic session. Well, what a way to close out. We have another world expert to cap the rest of the experts, Vlad Dzavik, who's going to talk to us about advances in bifurcation PCI.
Thank you very much. What I'd like to do is, I'm missing. How was I going to do this? Excellent. A few points where I think we have questions remaining. So optimal bifurcation strategy, I think we have some data from the past year that are, I think, enlightening. One of the things that I've looked at recently where the big publications are the idea of bifurcation angle, its effect on outcomes, and importantly as well, bifurcation angle change, and this is not something that we've talked about a lot. What is the optimal duration of dual antiplatelet therapy in patients undergoing bifurcation procedures? There's very little data on bifurcation patients in complex procedure trials. Very few bifurcation patients have actually been done. To kiss or not to kiss? I think that's still an ever-present question. If there's time. And one thing that I missed in this is the whole idea of DCB. So if we have time, I'll just briefly mention that, as there have been some trials in the past year that have looked at this. So bifurcation strategy, what's the optimal left main bifurcation technique? We've had obviously 2 competing trials that have looked at this and 2 ideologies, if you wish, of what to do for most patients. The DK Crush 5, of course, showed benefit of DK Crush 5 versus provisional strategy. At 3-year follow-up, they confirmed this. However, they also showed that it's patients mostly with complex bifurcation lesions that benefited more, and definition complex. What's definition? Of course, definition was derived from a study that they did, an observational study, with derived major and minor criteria. You had to have at least, one major criterion for left main and non-left main, and then 2 of these 6 minor criteria constituted a complex bifurcation lesion. In left mains, less than greater than 70%, and in non-left mains, greater than 90%. Those were the 2 major criteria, and then the minors. They confirmed this by doing a trial in complex definition, complex bifurcation patients of DK, not DK crush, but 2 stent techniques. Most were DK crush, not all, versus, again, a 1 stent approach, and confirmed that there was benefit in terms of TLR, target vessel MI, and TLF for the 2 stent technique. Contrary to this, the EBC, European Bifurcation Club, did a left main trial as well and found the exact opposite, that in fact the provisional approach was better, and in fact numerically, as you can see, perhaps somewhat better, but no difference in overall outcomes between systematic 2 stent and provisional approach. Why such a difference? Well, the difference is that in the DK crush studies, the side branch lesion lengths were considerably longer than in the EBC main trial. And in fact, recently, in the past year, the EBC main trial published its 3-year follow-up, showing the same outcomes as they had originally. However, they looked at now patients with side branch lesion lengths of less than 10 versus 10 or greater. And indeed, we see consistency with the DK crush results, where those patients with side branch lesion lengths of at least 10 millimeters actually did better with a 2 stent approach. Now, interestingly enough, this was not DK crush. These were other techniques, older techniques, perhaps even before we had better use of some of the other techniques, T-stent, culotte, etc. So consistency showing that if you have a long side branch lesion length, a more complex lesion, that 2 stent approach is better than 1 stent. Now, you have to do these well. So I wasn't going to show you the entirety of this slide, but you have to do these techniques well. This is a variation of the DK crush that we did, called the double crush, because we eliminate the first case, and here's why. So after you deploy the side branch stent, okay, you do a pot crush. In our version, you don't actually do a crush and then bring in a pot balloon. You do gentle inflation distally, then a full crush inflation with the same balloon in the left main. Okay, then you recross, of course, a proximal recross, very important, or non-distal recross, and you have your main vessel stent right there. So you open up the struts, and the main vessel stent is right there. You take out the balloon from the side branch and immediately deploy the main vessel stent, and then do, of course, the second pot, very important. Then recross and end up with a final kissing balloon inflation after a high pressure inflation of the side branch struts to make sure you open them up fully, and there's a final result. Is the final pot necessary after this? I think not, because you've done a pot in the second last step. And unless you do high pressure inflation of the kissing balloon inflation, it's not necessary. It's not going to distort the main vessel stent. So that's that. Now, bifurcation angle. This is from the Progress Bifurcation Registry, published just in the past few months, where they looked at a large group of patients and divided them according to the bifurcation angle. Less than 45, 45 to 70, and greater than 70, and looked at the outcomes of these patients who were undergoing provisional bifurcation stenting strategies. As you can see here, pretty similar except that the ones with the high angles were more likely to be left main bifurcations, as you can see. So that could be responsible for some of the differences in outcome. Side branch occlusion is what the study was looking at. Basically, it was much more prevalent in patients with low bifurcation angles. So with acute bifurcation angles, the sweet spot was somewhere near right angle, and then it increased again slightly with high bifurcation angles, which again were more likely to be left main bifurcation procedures. And this was interesting because the greatest at follow-up, which is 4 years, the highest incidence of MACE was in the highest bifurcation angle greater than 70 degrees. Similarly with death, those are both significant. Now, could it be because these are more likely to be left main bifurcations? Provisional stenting, when they looked at independent predictors, so side branch occlusion, first of all, was a big predictor of MACE. Age, as you can see, was a significant predictor of MACE. Left main bifurcation was a significant predictor of MACE. So again, acute low angle bifurcations, more likely to end up with side branch occlusion. Is recommended that perhaps you should consider, for sure protecting them, perhaps even consider in the larger side branch bifurcations a two-stent technique in the very acute ones as a preventive strategy for occlusion and therefore worse outcome in the long term. Now, what about the role of change in bifurcation angle? This is an example, 2 examples of studies. This was initially introduced by Watanabe and colleagues, the Colombo group, the MITO registry or the Milan New Tokyo registry, in which they found that patients with a large angle change between systole and diastole actually did much worse than those with low, with a median of 7.2 degrees. This was corroborated by a study from China, which again showed very similar results. Patients with a high bifurcation angle change had a much greater incidence of side branch or circumflex occlusion. And finally, just this year, much more detailed study by the same MITO group, which showed that, in fact, when you had a large bifurcation angle change greater than 7 degrees rather, that the outcome was much worse with a two-stent technique approach than with a single-stent technique approach. With those with a lower angle change, actually the two-stent technique was better in this particular situation. And you can see the same results here. Large bifurcation angle change group over here. Okay. Twice the incidence of target lesion failure with the two-stent technique than with the one-stent technique. So something to consider when we see this. This is not something we've been looking at. Again, the greatest predictor, independent predictor of bad outcome in the large BAC cohort is, in fact, the two-stent technique. This is just an example of a patient with a visibly big change in the bifurcation angle, and probably somewhere in the 17 degrees range. This was a provisional technique, actually. Post-PCI looked good at 8 months, severe restenosis or severe disease in the ostium of the circumflex. This was beautifully stented in a T-stent fashion by one of my colleagues. You can see very good result in the carina. And mere 5 months later, severe progression of disease in this particular patient. Intravascular imaging has been talked about a lot. This is specifically a bifurcation meta-analysis. And again, you must use intravascular imaging in these patients. They're high-risk patients otherwise. DAPT, short term. This was the host idea trial using a 3rd-generation DS looking at short 3 to 6 months versus longer term DAPT therapy. Very few bifurcation patients, however. And what they suggested was that the net adverse clinical events, which include target lesion failure and bleeding, actually favored shorter-term DAPT in these complex PCI patients. However, again, very few bifurcation patients. To contrast this, the ultra-bifurcat registry showed, when they looked at a large group of patients in their registry, divided them into DAPT 6 months or less, 6 to 12, and greater than 12. That's a mistake on my part right there. That's greater than 12 right there. Obviously not both, less than 6. And you can see these are high-risk patients, and found that, in fact, the MACE was the lowest in the DAPT greater than 12 months, highest in the short DAPT group. These are bifurcation patients. And the problem is that they didn't have systematic approach to looking at, documenting rather bleeding risk. So this is a hypothesis-generating study, but it gives us caution to use short DAPT in these bifurcation patients. DAPT shorter than 6 months, the greatest predictor of bad outcome in these patients. And this is what their Kaplan-Meier curve looked like. Again, DAPT, upfront 2-stent strategy especially. Okay. DAPT greater than 12 months, DAPT less than 6 months. So it's a very thought-provoking study. Makes one think that we should not be using short DAPT duration, but it needs more study. It needs proper randomized trials. I won't go over this because I think we're a little bit over time. Just to say, final kissing balloon dilatation in patients with coronary bifurcated lesions treated with upfront provisional strategy. This is a large registry. Bottom line is there is no difference between the two. Doing it final kissing balloon inflation versus not. However, just to point out that in left mains, it seems to make no difference. In true bifurcations, there's no difference in MACE, but may be a difference in TLR and stent thrombosis and any MI. So in true bifurcations, we should likely do that kissing balloon inflation at the end. In unprotected left mains, especially when there isn't one, I tend not to, and I think there's some data to suggest that this is not necessary. So a lot of things to think about and to work on in the future. Just like this iceberg, we're just seeing the tip, and a lot of work to do to see what's underneath it. Thank you very much for your attention.
All right. Vlad, before we go to discussion, we have a little time for discussion, but I want to do 2 quick things. First of all, everyone needs to know, and everyone is invited to the annual CVI party from 9 to 12. There's a live band, and I think Manos is going to sing. Oh, maybe not. And
I'm not sure.
So there's a live band between 9 and 12, and it's right next door at the Cedar Door Patio Bar and Grill. So everyone should come. Second of all, I want to say, Manos, stand up for a minute. Stand up. So this is this is always a highlight conference. And look at here, it is at 5:30 in the afternoon, and the room is packed. And so thank you for the speakers, thank you. But Manos really is in charge of the coronary track, does an amazing job, and thank you again for a wonderful year. And he's here for every talk, so I think...
It's not over yet. There's sessions tomorrow morning, just so you know.
And now we have time to talk about Vlad. That was a great talk about the update on bifurcations.
Vlad, can I ask you from a simpleton's question here? So DK crush versus regular crush. To my recollection, when DK crush first came about, it was in order to fit everything through a 6 French guide catheter. And now we have the slender sheath and sheathless, 7 French, 2 stents at once. It's 45 minutes quicker. I mean, can you make a good case for DK versus a...
Absolutely. The most important difference between a DK crush and a crush, whether it be a mini crush or whatever other kind of crush, is that you are stenting and you're trying to recross 3 layers of stent. If you just crush that side branch stent and then deploy a main vessel stent, you're going through 3 layers, and you're never going to open those struts as well as you can if you do it systematically, stepwise. Okay, so that's it. To me, it has nothing to do with 6 French, and it does help. And by the way, in the left mains and in the decrush that I described, I now use, for all my left mains, I use 7 French. Okay, that's, for left main, I don't think we should use 6 French systematically, because things can happen and you may need a lot of equipment in that area. So I use 7 French. In many cases radial, otherwise femoral. But that's the biggest benefit of the DK crush versus a crush.
That was an excellent talk, and I think you alluded to this because you didn't have time, but about DCB and side branch, because there's emerging data on that.
So earlier this year, Xiaoliang Chen and the same DK crush group published DCB BIF, okay, which was a randomized trial of DCB versus non-compliant balloon inflation in side branches, where you're doing provisional stenting, okay, or provisional side branch stenting. In other words, crossover single stent technique. It was positive trial. What gave me pause was that the curves separated at day 1. So they separated immediately. And I was actually watching Xiaoliang in Nanjing in December. I asked him this question, do you have data on what pressures were used with the non-compliant balloon, what pressure were used with the DCB? That was not available. And so that's the only thing where I have a little bit of concern, is that they really separate not at day 1, day 0. So that I'm not sure how to attribute that to the drug-coated balloon.
Great case, Vladimir. I mean, the Achilles tendon of the left main bifurcation, as you put in your case, is the ostial left circumflex. I see that especially with that angulation, that they tend to come back. So yeah. I've been thinking, especially in left dominant systems, to treat the LAD as the side branch and minimize the stent from left main to circumflex 1 layer. What would you do?
Are you talking about
that?
the one where we had the big bifurcation angle change? Well, I think the same thing's going to happen, because the swing's not occurring between the left main and LAD. It's occurring between left main and circ. So it's a circ that's the pendulum. It's not the LAD, right? So even if you stent, if you do crossover stenting from circ to left main, you're still going to have that problem. You're still going to have that problem of the tension, of the torsion, expansion, shear stresses on that ostium of the circumflex just by stenting it, even if you use that as the main vessel, for example.
I thought the DAP data was pretty interesting in bifurcation lesions, and I wonder, as the world sort of moves further along to single antiplatelet therapy with Plavix or clopidogrel, how those numbers would look, bleeding versus MACE rates in the coronaries, if we went, let's say, 3 months of DAPT, then single antiplatelet therapy with clopidogrel versus downgrading to aspirin to try and cut our bleeding risk but maintain the anti-ischemic properties that we're trying to follow.
Yeah, or ticagrelor, for which we already have data, right, as single therapy after 3 months. It's a excellent question, and the thing about the ultra bifurcat study is that they had those limitations. These were the observations that they had in a large group of patients, but the events in the patients with lower duration of DAT could be surrogates for something, that wasn't unmeasured. And the lower event rates in the greater than 12 months could also be surrogates for something that was unmeasured, a low-risk patient that wasn't captured in the registry. So I think it does need randomized trials, actually.
Final question and a brief answer.
Yeah, I was just going to say the same thing. I feel like in my experience, the patients who have ultra-late stent thrombosis are usually the only ultra-late, like 5 years, 7 years, are the ones with the bifurcation stents and like a diag that's 2.5. Yeah. So when I decide on DAP duration, I oftentimes want to know what the size of the stent was and if it had bifurcation. And in this day with the Panther meta-analysis and the Capri data from years ago, I use single antiplatelet chronic, in the chronic phase with P2Y12. Right. And I feel very comfortable that there's enough evidence to support my approach. I have that discussion with the patient and explain to them the standard of care is aspirin, but I'll use prolonged P2Y12
Yeah.
with Plavix.
No, that's a great point. I think the other thing is that we are recommending the use of intravascular imaging in all these patients, and even in these studies, the use was maybe a quarter to a third of all the patients who had intravascular imaging. I think the data may very well be different. I think my results are better with IV imaging than without, and so that all has to be tested.
Thanks to the speakers, to the panel, to the audience, what's been a fantastic session. Thanks again to Manos and all of his co-directors for an amazing meeting.